manual therapists. We are based out of North America. We have Dr. Hasan Rahman with us. He practices in the state of Ontario, Canada, and he'll be talking about rotator cuff injuries and different grades, a lot of cool information. I mean, this is a very, very common patient presentation we see in the clinic. So, I mean, it's a very, very handy information, a lot of treatment ideas, a lot of research. So, I mean, this is like direct application of what we see in the clinic and how we can use these ideas to help our patients.
Okay, move forward. Yeah, that's the same.
Yep. So as you know, I'm talking about Dr. Hasan Rahman. He practices in Ontario, Canada. He has done his bachelor's of PT from Bangladesh. He is doctor of physical therapy. He's done his certified orthopedic medicine, CSMT, CUMT. He's also an assistant professor for Just University, Bangladesh, and also a clinical lecturer for NOSM University. So he's been teaching for a while, and I've been practicing for a long time. So a lot of information you're getting, I think you'll not probably get this information anywhere else. Yeah. Dr. Steve is my partner in crime. We started this journey a few years ago, and then we started Gem Physio last year, 2022. Our idea was to bridge the gap between our primary education, which is BPT in India, and Doctor of Physical Therapy in the US or in North America. And the idea was to bring cutting edge clinical methods, evidence-based treatment methods for clinicians. Yeah. Me and Dr. Steve both are fellowship trained therapists from United States. I'm also, Dr. Steve and me both are orthopedic certified specialist or orthopedic clinical specialist from American PT Association. Okay. And that's why we do this, because I feel like we can make a difference in how you practice. Okay. Our understanding of how we practice has gone up with all the education we had, and I'm a much better therapist than how I started. I was a horrible therapist. I always say that when we started, and with this additional education, I think you can definitely help your patients better. Your understanding will improve. You will help people, which most people miss, because you definitely have better understanding after you go through the program. We run a 1-year program where we talk about different segments of the body. Which has 12 modules. It's a 1-year program, and we are starting cohort 3 in April, May timeframe. We're also traveling to India, me and both Dr. Steve, and we'll be teaching in Delhi for 6 days, and we'll be teaching in Bombay for 6 days, Mumbai for 6 days. And we keep sharing the flyers on the Instagram, social media, Instagram, Facebook, YouTube. And if you have any questions regarding meeting us or joining hands-on, have questions regarding joining it, you can reach out to Dr. Dhrumi. Okay. I still see people joining it. We can wait for like 5 more minutes, Dr. Rahman, and then we can get going. Okay. Yeah. This is an interesting topic because, this is probably one of the most common shoulder diagnoses we see in the clinic. So direct application to the concepts. Still see people joining in, and next weekend, we are teaching clinical differential diagnosis and clinical reasoning. Okay. And we're going to be talking about that lecture. I think it's an interesting lecture just because, differential diagnosis is an important component of important component of orthopedic practice. We try to teach almost every weekend with our team, our people in our masterclass, so that you guys can get like high quality information, latest research, evidence-based treatment methods. And for manual skills, I think we travel to India so that you can attend the hands-on. Yeah. Guys, wait for a couple of minutes and then we'll get going. Yeah.
Dr. Singh, do you want to talk about our modules we have in our
So
series?
guys, we have, yeah, well, why not? Yeah. So we have like 12 modules. I mean, our program is structured in a way that we teach one module every month. So that, and this is purely based on how any fellowship program runs in the US. So there's 1 weekend a month we meet, we talk about a certain topic. It could be foundations and biomechanics, that's a foundational topic. And then we have core modules where we teach 11 other modules and then followed by 2 electives. Okay. And to graduate through the program, you have to pass or take 14 courses. Okay. And take 14 courses and pass the quizzes, take the final exam, take the hands-on if you want to be a diplomat of GEM Physio. Yeah. Okay. The courses are very, very intense and we keep updating them because APTA orthopedic section and AARM keep updating the information. New research is coming out every month. And we try to keep up to date with what orthopedic section of APTA is saying, what sometimes sports section of APTA is saying. And being in US, being a member of both these organizations, I think I have that resource available where we share information on very, very frequently. And I think I see you, Dr. Rahman, on LinkedIn. I think you follow a lot of groups and you keep up with the clinical prediction guidelines and very latest stuff. I definitely follow you on LinkedIn very, very closely. All the posts you like and all the posts you share regarding
Thank you.
physical therapy. You're very passionate about it. Very nice.
Thank you very much.
I think this is a good time to start. I think we'll have people keep joining in, but I think this is a good time to start. And if you have any questions, I will be Dr. Rahman will be teaching, and I think I'll try to respond if Dr. Rahman gets busy.
Thank
Yeah.
you very much. So
I
we have a
think
quiz
you can
section.
start, Dr. Rahman.
So we have a quiz at the end. So I'll request to
Ye-
participate the quiz, like 10
Yes,
MCQ questions at the end.
yes, guys. So there is a quiz at the end. You have to take a 10-question quiz to get your certificate. Okay, so make sure that you don't miss the quiz, take the quiz. Okay, and pay close attention to what Dr. Rahman is teaching because this is a very, very interesting and important information. Yeah, thank you, Dr. Rahman, for doing this. I
Thank you,
appreciate it.
Dr. Singh. Thank you, everyone, for joining us today. I'll not take much time. Let's start. Our topic is exploring rotator cuff tears, surgery or not. So we'll try to discuss this topic in more detail so that we can decide whether patient should be referred to an orthopedic specialist or we should try the conservative treatment. So our learning objectives are, we will discuss about the classifications of rotator cuff tears and the etiology, sign and symptoms, how we can diagnose massive rotator cuff tears, and when to send for other tests like X-ray or refer to a specialist for MRI, and what could be the valid non-operative treatments based on current evidence, and when we should refer a patient to orthopedic specialist. So before I start, let me discuss about our tendon structures, anatomy, some basic stuff. So probably we all know we have the tendon is started on the bone, so that is called tenoperiosteal junction. So if I use my pen, so here you can see A is our bone, and this is our supraspinatus tendon. It is inserted on the bone. It's called tenoperiosteal junction. So tendon and bone, that junction is called tenoperiosteal junction. And then B is tendon, and the C is muscle tendon junction. So our D is our muscle, B is the tendon, so C is the musculotendinous junction. So these few things you should know. So structure-wise, tenoperiosteal junction, tendon, musculotendinous junction, and then muscle. So when we discuss more about the tear, we should know, because this words will come more often: articular surface, bursal surface. So for a tendon, the articular surface is the bottom part of the tendon, is close to the bones. Okay, this is the bottom part. It's called articular surface. This is the articular surface, and the surface on the top is called bursal surface. The bursa sits here. So we have subdeltoid or subacromial bursa. So the portion of the tendon that close to the bursa is called bursal surface, and the other surface, the bottom surface, called the articular surface. And we know the basic anatomical location. If you think this is your humerus, this is your anterior aspect, this is the posterior. So the anterior aspect, we have subscapularis, and subscapularis has two different parts, superior and inferior. So you can see this is superior, it's inferior. On the top, or the superior part of the humeral head, we have supraspinatus, and the posterior part we have infra and teres minor. So this is very important because if patient have complete subscapularis tear, then usually we find patient have a poor prognosis. And this is not very common. Subscapularis tear is not very common. Common is mostly supraspinatus and infraspinatus. These two tendons get torn on the most of the time, almost 70%, 80% case, you will find that these tendons are involved. But sometimes subscapularism is involved, then as I said, the prognosis could be, it may take time to heal, or the prognosis might not be good. Okay. So when I say, okay, anterior aspect of the rotator cuff is involved, that indicates the subscapularis. When I will say superior aspect, then it indicates the supraspinatus. If I say the posterior aspect of the rotator cuffs are involved, then it indicates the infra and the teres minor. There is important information here, critical zone for supraspinous tendon. So several studies suggest that blood supply is not uniform in supraspinatus tendon and relatively hypovascular, especially 10 millimeter proximal to the insertion. So if you think this is the insertion point, then likely this area is a critical zone due to the lack of blood supply. So this area tends to uh, prone to tear. If you overuse or any trauma or injury, this area might have a tear. That is a kind of very prone, or maximum time you will find this critical zone patient have a tear. This is important. So approximately 10 centimeter proximal to the insertion, that is the critical zone for the supraspinatus. Okay, so there's another important information here. It says disposition of the vessel. So when you move your shoulder, like abduction, adduction, elevation, so there is a disposition of the vessels. Like you can see on the number one, when you're doing abduction or arm elevation, the vessels are kind of uniform, the supply is uniform. But when you're doing adduction, the blood supply, it became less in this area, the critical zone. So that means if you do a lot of adduction movement, and if your job involves a lot of adduction, and it can also cause some compression force. So compression force and adduction, and repeatedly you have lack of blood supply this area, then you're prone to develop degenerative tendon tear in future. That's why you can see with the movement and compression force that can hinder your blood supply to the tendons. So this is also important, interesting information to know. Especially, it says, note the mechanism of wringing out the vessels by compression during shoulder adduction. Okay, so another important slide here, tendon load and capacity. So especially these actually three forces that can lead some issue in the tendon. If you do repeatedly this kind of loading on the tendon, excessive loading, especially the tension loading, compression loading, and shearing loading. The tension loading is, you can see the picture here. Tension loading is when the force goes like counter force. Like it says tensile stress applied when two forces pulled in opposite direction. For example, tension increases with the arm elevation. When you do the arm elevation, it creates some tensile load in the tendon. Next, compression load. During specific movements, tendons become compressed against the bony protuberance. That means when it gets compressed, any kind of bony structure, it creates some compressive loads. Especially when you have shoulder impingement, the compressing load on the tendon becomes more and can develop some tendinopathy. And when these two forces combine together, tension and compression, that is most provocative. Okay, so this is very important information. When tensile load plus compressing load works together, and this is the most provocative, and it can cause symptoms for the tendon. So there's another force called shearing force, intertendon force. Shearing increases with the arm elevation. For example, you can see on the bottom picture. So shearing force kind of more goes kind of inside the tendon. There's some fascicles. So fascicles move kind of opposite direction, and that can cause some shearing force. So intertendon force, shear increases with the arm elevation. The shearing force can cause some cellular damage in the tendon fascicles. So I'll show you in the next slide. There's an article. It says that if you have a lot of shearing force, it can cause some damage in the fascicles. So this is tendon structures. Few tropocollagen from a microfibril, and few microfibril from the fibril, and then it forms the fascicles, and few fascicles when it's kind of encased in a epitendon sheath that forms the actual tendon. So when you have a lot of shearing force, these fascicles can get damaged. So you can see this is one fascicles, another fascicle. They're all fascicles, and that can get damaged. You have a shearing force. Okay, so how this tendon tear occurs? So it could be two different ways. One could be traumatic, and another could be non-traumatic or degenerative. So here is a question for everyone. You can see here there are three different examples here: fall on outstretched hand, and shoulder dislocation, and forceful external rotation. So what do you think? Like when patient have an external rotation, forceful, which tendon can be get injured? You can write in the chat box. When patient have a forced external rotation, which tendon can be get torn? They can see the chat box. So the answer is when you have external rotation, there is a high chance that you might injure your subscapularis. Okay. Same thing when you have anterior shoulder dislocation, there is a chance that you may injure your subscapularis. But when you're falling in the outstretched hand, for example, you can see here like this, you may have supraspinous can get torn when you fallen out a stressed hand. Okay? So it can lead to a full thickness tear when you have this kind of force traumatic events can happen. So you may have a full tear in your supra or your subscapularis tendons. And another is non-traumatic. That means overuse, repeated use, that might be from your job or, your daily activities, your hobbies. If you do something again and again, and if you are putting too much load in this hypovascular area or the critical zones, then you may develop some degenerative tendon tear. So I said two different etiology. One is the traumatic and non-traumatic, because those two are important when you decide whether the patient should try the conservative first or they should go for any surgical intervention. Okay, now let's watch a video. It's a very, very basic video about the anatomy and different parts of the tendons. Let's see.
The rotator cuff comprises a set of four muscles that serve to stabilize the shoulder, including the infraspinatus, supraspinatus, teres minor, and subscapularis. They connect the scapula to the humerus. The tendons of these muscles may become torn where they attached onto the humerus bone due to impact or excessive stress on the shoulder, leading to pain and limited mobility of the region.
Okay, so there is another good information here. You can see the right side. I mentioned the healthy tendon, and due to degeneration, patient may develop tendinopathy, and later they may develop rotator cuff tear. But when you have a trauma or injury, tendon can get torn directly from direct trauma.
The rotator.
Okay, this is also important slide. It's a very busy slide. So classification of rotator cuff, partial thickness tear. This is not a full tear, but partial thickness tear. We can divide like size and location. So if you think like on the right side, we can divide in three different grade 1, grade 2, and grade 3. If the tear is less than 1/4 thickness, then we can decide this is a grade 1. If it is less than 50%, then it could be grade 2. If it is more than 50%, then we can classify this as a grade 3. So grade 1, grade 2, and grade 3. And for site and location, so if the tear happened in the articular surface, then it could be, I can say articular tear. On the bursal surface, then the bursal tear. It could be also intersubstance. That means the partial thickness tears that neither extend to the articular nor the bursal surface. So it is not extended to the articular or the bursal surface, is in between. Then we can say the intersubstance tear. So this information is very important, because when you read an MRI report, you might see sometimes it says the report says articular surface tear or intersubstance tear, so that we know what they're saying. Okay. Now full thickness tear. So according to the size, we can divide is four different kind of part, like four different types. If it is less than 1 centimeter, then it's a small tear. 1 to 3 is medium, 3 to 5 is large, and massive will be more than 5 centimeters. So this is very important information. So if you see MRI report, sometimes you will find 5 centimeters, 6 centimeters, even more, like more than that. That means that patient have a massive tear. And here you can also see the retraction of the tendon. For supraspinatus tendon, this is kind of over the top of the humeral head, and it retracted more. Now it is medial to the glenoid. So this is very important information. When you see any MRI report, patient have a retraction medial to the glenoid, that indicates that patient prognosis could be very poor. So this is important. So full thickness tear we divide in four different categories: small, medium, large, and massive. So massive will be more than 5 centimeters. Okay. So this is this slide based on Collins' article. They divide this tear in four different parts, like 5 different. So type 1, Type 1 is superior subscapular. So I mentioned before, the subscapular has two parts, superior and inferior. So if you see that type 1, this is subscapularis. And you can see only the superior part is involved and the supraspinatus are involved. So supra and superior part of the subscapularis, that makes type 1. Type 2 is complete subscapularis. Here you can see the superior part, inferior part, both are gone, and supraspinatus is also involved. So this is type B. And as I mentioned that when subscapularis is kind of completely torn, then the outcome may be poor. So type B, you can see complete subscapularis and supra are involved. So probably type B, the prognosis would be poor. Type C, here you can see superior subscapularis. That means your inferior subscapularis is intact. Only the superior part is involved, and supra and infra both are involved. So here 3 tendons are involved, but inferior part of the subscapularis is okay. For type 2, infra and supraspinatus involved. Type E, teres minor, infraspinatus and supraspinatus are kind of intact, torn, but the subscapularis are intact. So here the important information is, if the tendons are more than 3 tendons or more than 2 tendons are involved, then we can see is a massive tear. And the patient have their subscapularis are fully kind of torn, like upper part, superior part, inferior part, both are gone, then usually the prognosis are poor. Okay, so this is there are another two important information: tendon retraction and fatty infiltration. So tendon retraction is, as I mentioned, then you can divide in 3 different stages. Stage 1, when the tear is close to the insertion, you can see here there's no retraction. So this is stage 1. When it progresses further, it gets worse. Then this retraction can be on the level of humeral head. And further, if it gets even worse, then this tendon can be retracted medial to the glenoid. So this is stage 3. So stage 1, stage 2, stage 3. So you can understand that in stage 3, the prognosis will be poor. And there is some fatty infiltration can happen in the muscle. So at the beginning, it could be some fatty tissue might build up in the tendon area, muscle, and later the fat, some fatty tissue, but is less than muscle. But later, if it gets worse, then fat muscle might be the equal amount. Then it can get worse, and then fatty tissue can even take over. So it's called fatty infiltration. So these are all important information when you decide whether patient should go for to see a specialist. If patient have a kind of grade 3 tendon retraction level medial to glenoid, patient have more fatty infiltration than muscle, then usually the prognosis are poor. So there's an article here I included. It says retraction of the supraspinatus as predictors of success of rotator cuff repair surgery. That means the supra, if it is retracted and fatty infiltration is there, then there is a less chance that the repair surgery, the outcome might not be a good idea. Because if the tendon is not retracted, that means the idea is, if you wait too long and the tendon is retracted, lots of fatty build up in the muscle or the rotator cuff muscle, then even if you go for surgery, then it can be a failure. Okay, so that's why you have to decide whether the patient should wait and see, try the conservative, or they should go for to see a specialist. So muscle atrophy. See here you can see 4 different kind of images. This is the oblique sagittal plane view. This is our scapula, and this is our suprascapular fossa, where the supraspinatus sits. So here, the different level of muscle atrophy. So on the right-hand side, you can see this is the normal kind of oblique sagittal plane view. This is our spine of the scapula. And on the top, we have supraspinatus tendon. On the anterior aspect, we have subscapularis. Posterior aspect, we have infraspinatus and teres minor. This is the normal healthy kind of structure. But as you can see, when you have healthy structure, the muscle is convex above the line. If you draw a line like this, so the muscle goes above the line. That is normal, healthy muscle. It should go above the line. But when it comes kind of the same level, it indicates that there is some atrophy is there. If it is behind the line, then more, I should say, moderate level of atrophy present. And when it's really kind of barely any muscle visible, that indicates that patient have severe muscle atrophy. Okay. And we know all that force couple, because our deltoid muscle and our rotator cuff muscle should work in a balanced way. If something happen in our rotator cuff muscle or the tendons due to the tear or tendinopathy, so this force couple gets disrupted. So here you can see the deltoid causing some superior shearing force, and our rotator cuff muscle causing some kind of, it counteract with this superior shearing force. So in case the rotator cuff is not intact, something happen, this shearing force become more prominent and it take over, and it can cause some impingement. So this is important information, because when you discuss this in next few slides, you will see how this superior glide or superior force can cause some impingement and develop some arthritis in the shoulder joints. It's called rotator cuff arthropathy. When you have this kind of force couple doesn't work normally, and there is more superior force or superior migration of the humeral head, it can cause some arthritis in this margin of the humeral head. So it says rotator cuff arthropathy, specific pattern of shoulder degenerative joint disease that results from a rotator cuff tear. This is primary, the reason is tear, leading to abnormal glenohumeral wear and subsequent superior migration. So in the X-ray, you'll see this kind of arthritic change on the superior margin of the humeral head. This could be the secondary to your rotator cuff tear, because there is a superior migration of the humeral head and causing some pressure and some kind of structural disruption. Okay. So this is very common. Most of the time when patient comes to us with a massive tear, we see patient, if you ask them to lift their arm up, they shrug their shoulder and then try to do compensatory movement. So it's called pseudoparalysis, inability to actively initiate or elevate the arm. And if you have this for a long time, that can lead to rotator cuff arthropathy. So if you do not correct this type of pattern of movement, every time you try to lift the arm up, it's called superior migration, and eventually that can lead to arthritis or arthropathy on the superior margin of the humeral head. And if this lasts for a long time, patient have massive tear, then as I said, the prognosis is not good. Patient may have to go for reverse shoulder arthroplasty. And I see a lot of patients with reverse shoulder arthroplasty. The good thing is I find they are completely pain-free, but their movement is a little bit limited. They don't have a full range of motion, but they can sleep better, they're pain-free, and they're doing really good with this kind of surgery. So if patient have this kind of arthritis due to this pseudoparalysis, massive tear, then reverse shoulder arthroplasty is the treatment of choice. In another picture, you can see there's a visible muscle atrophy on the supraspinatus area and the infraspinatus area. Okay, let's go to the next slide. So before I kind of discuss about the treatment, we should know a few things about like our sling, our fascial slings in our body. So here I added in important slides. So probably you know we have few slings in our body that helps to transmit our force. Okay, when I do any movement, limb movement, the force transmits from one place to another. So we have anterior sling, posterior sling, deep longitudinal sling, and lateral sling. So when you in any disruption, any dysfunction happen in your any part of your sling, that can affect your proximal part, your distal part. So that it should be working in a proper way. So even in this dysfunctional sling, we should work on it, and you have to work kind of not only where the problem is, we should work on other area. For example, if you have any gluteal muscle weakness, your back extensor weakness, it can affect your other part. Like for example, your uh, shoulder movement, or it can affect your function. That's why when we do any treatment for shoulder problem, when we engage rotator cuff muscle, we try to engage the sling so that it helps to put less pressure on the rotator cuff muscle. That makes rotator cuffs function easier when you engage the sling. So we'll show you some practical videos how we can engage the sling. So there's another important slide. I took it from Jeremy Lewis. He's a shoulder specialist, UK based. He's a very renowned physio from his website. So here you can see, like when we anyone do kind of tennis serve or serving a tennis ball, so the 54% energy comes from your legs and trunk. So although we are using our elbow, shoulder, upper limb, but you can see the 54% energy comes from our legs and trunks. So if somebody has a dysfunctional kind of, for example, gluteal muscles are weak or core muscles are weak, then patient will not do the best. So that's why we need to engage the kind of kinetic chain area to so that if they function well, it can put less strain in our shoulder. Now let's discuss a case. It's a real case. I saw this patient a few weeks ago. It's an 80-year-old lady complained of right anterolateral shoulder pain. So anterolateral shoulder pain for last 3 years. In serious onset, patient had a history, rotator cuff repair about 20 years ago. So on the X-ray, it shows some calcific tendinopathy, especially the supraspinatus tendon. So I try to relate what we discussed so far. You'll find few things are kind of familiar, you know. So patient have degeneration or arthritis severe on the right glenohumeral joint. Patient had high riding humerus. High riding humerus means patient humerus is migrated superiorly, and it suggested rotator cuff degeneration. So this is X-ray. This is not ultrasound or MRI. So X-ray shows that patient have tendinopathy, some arthritis, severe arthritis on the glenohumeral joint, and superior margin migration of the humeral head. So here, patient had a rotator cuff tear 20 years ago. So since patient doesn't have the ultrasound, it's hard to say patient have a tear. But from this kind of case, I can understand there is a chance the patient have a tear because patient had a rotator cuff repair long time ago, and when you have rotator cuff repair, you can develop this arthritis in later life. So that's kind of one indication. Since he had a rotator cuff repair 20 years ago, that is the reason for patient have arthritis. And since there is a high riding or superior migration of the humeral head, and patient have pseudo paralysis, there is a chance the patient also have rotator cuff tear. So if I show the video, and this is the X-ray report, what I discussed right now. So this is the patient. You can see how she's doing her flexion, abduction, and internal rotation. Can you lift your right arm up, please? Let's see how far you can go. And with support, you can go further, okay? I can bring it down. Let's see sideways, how far you can go sideways. Okay, I guess it's very limited. What about hand, right hand behind back? It's also very limited. How is it pain level? Like out of 10, how is it pain?
I can't go no further.
No further. Okay. So here I included this video and the slide just to let you know that since we don't have any ultrasound or MRI, we cannot say patient have a tear. We can do the tests for, but from here I can understand that since the patient have repair long time ago, it may develop the arthritis in the later part of the life. Since the patient have superior migration of the humeral head, so that might be also the reason patient have this arthritis. And you can see this flexion is very much limited. And if your patient will try, you might see some kind of pseudo paralysis. Can you lift it? Okay, now we can do some tests to determine patient kind of which tendon are involved. So individual tests are not that reliable. When you do the cluster of tests, when you do the subjective and objectives, then you can reach a diagnosis. But these are all kind of, it has some few tests have a good specificity, some sensitivity are high, but few are not quite reliable. But when you do cluster of tests, then as I said, our diagnosis can be more accurate. So for the drop arm test, is mostly for the supraspinatus tendon and also engage the infraspinatus. External rotation lag sign. So I'll show you all the videos how to perform in a correct way. External rotation lag sign is mostly for the infraspinatus. Internal rotation lag sign is mostly for the subscapularis. Lift up test for the subscapularis inferior part. And belly press is for the superior part of the subscapularis. Okay, so drop arm test. You can see the sensitivity is 73, specificity is 77. So I'll show you how to do that, perform the drop arm sign. Patient, I'm gonna help the patient lift the arm up and let go and see if the patient can hold the position. Okay, this is drop arm sign. Then external rotation lag signs. I'm gonna discuss this. You can see the sensitivity is 46, very poor sensitivity. Specificity is 94. Then internal rotation lag sign is for the subscapularis. The sensitivity is really high. You can see 100%. And the specificity is 84. So let me show you the video so that you know how to perform this. So probably you already know beforehand, but just to review the test one more time, okay? So first I'm going to show the drop arm sign. The beginning, I'm going to lift the patient's arm passively, lifting it up sideways and external rotation. And I'm going to let go of this position and ask the patient to hold the position. And if the arm drops 5 degrees or more, the test is positive. And this is for supraspinatus and infraspinatus muscle tear. The next test, I'm going to do external rotation lag sign. I'm going to lift the arm up 90 degrees, forward flexion, horizontal abduction, and basically full external rotation. I'm going to ask the patient to hold the position. If the arm goes forward, falls forward, the test is positive for infraspinatus and teres minor. And the third test is internal rotation lag sign. Patient will bring his hand behind his back, and I'm going to passively move forward. Ask the patient to hold the position. If the patient cannot hold, if it drops forward, then the test is positive, and this is for subscapularis. So next test is lift off test, the same position. I will ask the patient to push against my hand, lift off away from the body. And if I see patient have any weakness or tenderness or complaint of pain, then the test is positive. The last test is the belly press test. Is for the subscapularis. Ask the patient to bring the arm forward and ask the patient to push forward this way. So it's kind of belly press. The patient kind of press against my hand. this is, if the test is positive, then this is for subscapularis upper portion. So these are the tests you can do to determine which tendons are involved. Okay, so asymptomatic rotator cuff tear. This is also important slide. At the age of 65 years, approximately 25% of people will have an asymptomatic rotator cuff tear on imaging. So um, at 65 years old, any patient, any people who do go for any kind of investigation, MRI, you will find almost 25 people have rotator cuff tear, but they don't have any symptoms. And this increased to approximately 50% by the age of 8 years, and it can increase in like next few decades. It can get worse. So the decision is diagnosis is not based on the image. We should not rely on the imaging alone. We should also do the clinical test. So this is also like so you should know that the test or MRI is positive. It doesn't mean patient will have the symptoms. Okay. Okay, tear size progression. So if it is non-traumatic, then healing could be, I should say, the less potential to heal. And most of the time you'll find the over next few years or 10 years, 15 years, it can get worse. So you can see there is a slide, there's a picture here on the left side. There are 24 cases. If you see here, the first MRI and the second MRI, you will see few cases that are a little bit healing occurred. So you can see the case one. First MRI shows 195 millimeter, and it gets slightly better in the second MRI. Second, again, this one again gets better. A few are getting worse. For example, you can see 232 become 256, 540 becomes 1015. So you can see that it can get better, it can get healed, but most of the time, eventually it gets bigger and it gets worse. Although the tear may not heal. So is one other important information here. So when the patient comes to us for therapy, we tell the patient, our aim is not to heal the tendon. Our aim is to function better, so that after the therapy you should be able to move better. Your elevation should be less pain-free. So that's our goal. We do not say the patient that the tendon is going to heal and you will get better. So although the tendon may not heal, non-surgical management has similar outcomes to surgery for small, medium, atraumatic supraspinous tear in older patients. So if it is atraumatic, there's no history of trauma. If the size is less than 5 centimeter, and if it is a supraspinous involved, then the study shows that non-surgical management has a similar outcome like the surgical treatment. Outcomes of surgical and non-surgical management are similar for atraumatic, small to medium, isolated supraspinous tear. But if the tendon is more than 20 tendons are involved, if the subscapularis are involved, the patient have a retraction of the tendon I mentioned before, medial to the glenoid, patient have pseudo-paralysis, and is not getting any better after 6 months of treatment, then I say the prognosis is poor. Okay. For patient with this type of tear, non-surgical management affords less risk and cost. So if patient have a small to medium tear, only one tendon or two tendons are involved, and if there is no history of trauma, definitely we should try the conservative treatment first. Another article is rehabilitation effective in massive rotator cuff tears. This is a very important article from these authors. And I think I'm going to share this kind of article to everyone. And we should all read this article. It's a very important article regarding this massive rotator cuff tear rehab. So there are a few things before I start discussing about the treatment. Massive rotator cuff tears comprise up to 40% of all rotator cuff tears. So 40%, I should say, is a kind of huge, I should say, percentage of the people have massive rotator cuff tears. Patient with massive rotator cuff tears can respond favorably to non-surgical treatment. There's an article 2018. Non-surgical treatment should be attempted for 6 months. So if I want to try the conservative treatment, we should at least try for 6 months, or we should educate the patient. They should continue the exercise program for 6 months at least before they go for any kind of surgical intervention. Non-surgical treatment should be considered with a medical history. If somebody has some risk factor for surgery, they should try the non-surgical treatment first. So before, it's like when you decide whether patient should be going for conservative or surgical, we should think about these few factors. Tear size. If it is more than 5 millimeter, there is a massive tear. Location is important, is in the critical zone or not. And if patient have any muscle atrophy, if somebody have severe atrophy and the fatty infiltration, I discussed before, if the fatty infiltration is more than the muscle, then the prognosis could be poor. Even if you go for surgery, if patient have a kind of massive, kind of severe atrophy, very kind of high level of fatty infiltration, surgery can be a failure and might not be giving a good result. Patient's hobby and occupation is very important. If they go back to their previous occupation that involve a lot of lifting, pushing, overhead activities, it can lead to further tear. And patient expectation is also important. Like, as I said, this is a lengthy rehab process. If patient is not motivated to continue, then the outcome might not be very good. As I said, we educate the patient that our aim is not to heal the tendon. Our aim is to function you better. Okay, now let's discuss with the rehab of the rotator cuff tear. We discussed a lot of theoretical part. Now we're going to discuss kind of more practicals and what we should be doing. Okay. So management option, what are the options we have? So for non-surgical, if patient have a lot of pain, patient might take some anti-inflammatory to relieve some pain. Physiotherapy, as I mentioned. Sometimes they can go for corticosteroid injections and the pain is very bad, then they can go for suprascapular nerve block. So that might help with your rehab process. If somebody have a nerve block, they can do their exercise better. Surgical options are arthroscope, biceps tenotomy, tendon transfer, and capsule reconstruction. And I mentioned that reverse shoulder arthroplasty, if somebody have massive tear, subscapularies are involved, pseudoparalysis is not getting any better, and 6 months of conservative treatment and tendon retraction medial to glenoid, then probably reverse arthroplasty could be a better choice. Okay. For the non-operative management, the indications are for the non-operative, elderly patient, like it is more than 65 years old. So if somebody have kind of elderly, like 65 years old, then we should try the non-operative treatment first. If 2 tendons or more than 2 tendons are involved, if it is posterior superior tear is so posterior superior tear means posterior means our infraspinatus and superior means our supraspinatus. If somebody have infra and supra involved, then definitely we should try the conservative. But as I said, subscapularis has a poor prognosis. If somebody have subscapularis full tear, then the prognosis is poor. And if patient is kind of low functioning, like they don't have much demand on the shoulder, then probably non-operative treatment would be a better option. If somebody does not like surgery, if they refuse surgery, then we should definitely should try the non-operative treatment. Or if somebody have any surgical risk factors, for example, if somebody have Parkinson's disease, for example, somebody have active cancer. So these are all kind of probably not first choice of treatment, surgery. In that case, non-operative treatment should be first choice. The duration of treatment, 6 months before considering surgery. So we have to at least, patient should continue the conservative treatment for 6 months. Because most of the studies, they actually conducted this treatment for 6 months to 9 months. So as I say, like the outcome is slow, but definitely it's worth trying before considering the surgery. If patient is less than 65 years, younger patient, probably suitable for earlier repair. If patient is kind of less than 65 years, like younger patient, and have massive tear, especially traumatic, they should go for the tear earlier repair. Because if you delay repair, the problem is the repair, the tear can gets worse. It can get bigger. It can cause some tendon retraction, muscle atrophy, and then if you go for a repair even later life, might not give you a better result. So if somebody is younger patient, have a traumatic history, massive tear, they should get earlier surgery. So getting to get earlier repair to get kind of to function better and to avoid other complications. Because there is a chance that there is a high risk of tear progression. If you delay it long, then there is a chance that the tear might get progressed eventually. Okay. So when to refer a orthopedic surgeon? So if somebody have an acute massive tear in young patient, like less than 65 years, massive tear with complete subscapular. I mentioned subscapular is an important muscle because subscapular is a very strong muscle. I should say, comparing other three kind of rotator cuff muscle, this is like even bigger than kind of all other three, and it's very strong because it has strong muscle and a big insertion area on the anterior aspect of the shoulder. And usually, so subscapular doesn't get torn. Most of the time, as I said, supra and infra are the kind of get involved, like any kind of tear. But subscapular is rare. But if it happens, then usually the prognosis is not good. And if somebody fail after conservative treatment for 6 months, still having a lot of pain, still having pseudo paralysis, then I mentioned here in presence of pseudo paralysis and complete subscapular tendon tear, patient requires early surgical repair due to risk of development of early atrophy and fatty infiltration. So this is very important. So if somebody have pseudo paralysis, not getting better after 6 months of conservative treatment, and have a subscapular involvement, I said complete. I did not say partial. The subscapular has two parts, superior part, inferior part. If it is one still intact, we should try conservative. But if it's a complete subscapular tear, superior, inferior, both are gone, and patient have pseudoparalysis, then surgical repair early, if patient is less than 65 years, is a better choice. Okay, other patients who are probably candidate for surgery. If patient is young, non-traumatic, massive tear with significant weakness and pain, probably suitable for earlier repair if failure to improve symptoms after conservative. So I mentioned that if you tried for 6 months, it did not help, and significant pain and weakness, the patient should go for early repair. And patient have arthritis, it's called calf tear, advanced calf rotator cuff arthritis, then patient should go for surgery. Okay, the prognostic factors for rehab. So massive rotator cuff tear, the positive prognosis, when we can expect a positive prognosis, if isolated posterior superior tear, means superior, posterior means our infra and supra is involved, less than two tendons are involved, then our prognosis is better. And the poor prognosis when patient have massive anterior tear. Anterior means like our subscapular is complete tear, and more than three tendons are involved, then prognosis is poor. Okay, if it is a traumatic tear, if something happened, patient had a fall or any kind of injury, and patient had a tear, then positive prognosis if patient is younger and smaller tear is less than 1 centimeter, then if you go with the conservative treatment, the prognosis is better. If it is a traumatic history, if it is a large tear, multi-tendons like 3 tendons are involved or more than 2, and there's a tendon retraction to glenoid, then prognosis is poor. In that case, patient should go for early repair. Also, there is some risk of non-operative management. If you delay, if patient is in younger patient, traumatic history, and as I said, there's some other issues. If you delay, then what can happen? Patient have more fatty infiltration, tendon can retract it more, and that tear size can progressively get worse, and patient in later life, they may develop some rotator cuff arthropathy. Okay, so I'm going to skip this one because we already discussed this one, different kind of retraction, different stages. Okay, now let's discuss about the conservative treatment. So when you advise any kind of any treatment or any exercise to do at home, usually I according to the based on the evidence, we should start with the short lever, because if you start with the long lever, it can put too much load in the shoulder. So if you start with the short lever, this is kind of less provocative, and patient should modify their activities at home. Posture correction, if somebody have kind of postural issue like thoracic kyphosis or rounded shoulders, we also address those problems. Just restore range of motion, scapula, glenohumeral joint. If patient have a lot of pain, cannot concentrate or cannot do much exercise, then in that case, maybe some anti-inflammatory nerve block, as I say, suprascapular nerve block, corticosteroid injections, beside the conservative treatment, might be a good adjunct. Also patient education, time frame, how long it might take, and what could be the prognosis, that should discuss with the patient. Okay, so different articles, they actually highlighted about the retraining the deltoid. So they said start with the deltoid, and if you have a good deltoid muscle function, patient have a better elevation. So some studies, it says that start with the retraining the deltoid, retrain the teres minor, especially the tendons that are intact. For example, if you have subscapularis is torn, if your superior is involved, but one part is still intact, still you can engage this part of the subscapularis. If your teres minor is still kind of okay, there's no issue, you should engage the external rotation. So when you advise any treatment, we should think about which tendons are still intact so that we can engage those in our rehab program. So it says restore elevation, external rotation, retrain deltoid in elevation and external rotation. Effectiveness related to the tear size and location. Short term, 6 months conservative treatment should be done at the beginning. Okay, so you can see the arm elevation. You can start with the short arm, then long arm. You can start with the active assisted, then active. Okay. So let me show you a video, the important video, so that you know how to perform this this technique. So here you can see like deltoid activation you can do in supine lying, so that gravity is not gonna kind of almost gravity-free position, or less gravitational force kind of hinders your movement. So supine lying is a better position with active assisted elevation, then bilateral arm elevation. Then you can go inclined position, and then you can do a standing position. So you're progressively making kind of loading the tendon more. So let's show you the video so that it's easy to understand. So here title is anterior deltoid retraining with co-contraction with intact cuff. So as I mentioned, that if you have some part of the rotator cuff muscles are still intact, you can engage those rotator cuff when you do the elevation. So I'll show the video how you can perform in a clinic setting. It's a very important video. I hopefully you'll get a better understanding what I'm saying theoretically. Okay. Okay, this patient has a massive rotator tear on the left side, left shoulder. So I'm going to teach how to start the initial exercise, engaging the anterior deltoid muscle. So I'll ask the patient to bend this elbow. So this is a short lever. So I'll ask the patient to lift from here to long lever. So the patient will try to do this without any help. And ask the patient to lift this up this way. If it is painful, then patient can use his opposite hand to support. Very minimal support. So short to long lever. And if it is pain-free, then patient can try to go for the elevated position. So again, starting from the short lever to long lever and elevation. So I'll ask the patient to do the same, short lever to long lever and elevation. So if it is painful, then we may add light weight, maybe a dumbbell, 3-pound weight. Same thing, patient start from the short lever, short lever to long lever, and if it is pain-free, then patient can try to go further back. For the elevation, again, short lever, long lever, and elevation. Okay, so if I find the patient has intact teres minor or external rotator, we can engage the teres minor using an elastic band. So in that case, patient is gonna put the band around the wrist. So ask the patient to do some external rotation. So here again, short lever. So here patient is engaging his teres minor or external rotator, the intact part of the rotator cuff muscle. Again, from short lever to long lever. Again, bring it down. Do it again. And if patient is pain-free, then he can go further back for the elevation. And bend your elbow and lowering it down. So here we are engaging the intact part of the rotator cuff muscle. And at the same time, we are engaging other muscles like serratus anterior, anterior deltoid. So if I want to engage the kinetic chain, posterior kinetic chain, I'll ask the patient to do the bridging when he's lifting his arm up. So I'll ask the patient when he's lifting the arm up, he's gonna do the bridging and lowering down. So here we are engaging the kinetic chain. So it might be less stressful for the rotator cuff muscle when we are engaging the other muscles. So when patient's subscapularis muscles are intact, or part of the subscapularis are intact, then we can engage the subscapularis. We can use a kind of gymnastic ball. For example, patient's gonna hold the ball and gently push from both sides to engage the internal rotator. Again, from short lever to long lever. Again, from short to long lever. And if it is pain-free, then patient can go going up, or more elevation. Again, if you want to engage the kinetic chain, I can ask the patient to, when lifting, patient can do the bridging at the same time. So when he's lifting, he's going to lift the bottom of the bed and down. So here I'm engaging the kinetic chain so that it put less stress for in the rotator cuff muscle. Okay. Thank you very much.
Awesome.
Look, I think this is a bit quite clear, huh? How to do the elevation, how to engage the kinetic chain, what we discussed so far, okay? Now I'm going to go quick because we are running a little bit late. Same thing, elevation in different plane, supine position, incline, and then progression is standing. There's another muscle we need to work on, external rotator. So patient can do a side lying position and then progress to standing position using the elastic band. For this step, like those have massive rotator cuff tear. The functional MRI shows that the cortical part of their brain is also like kind of affected. So when you do this exercise, we need to also do some proprioceptive training. Patient can lay and they can draw alphabet, and they can make a circle. So that is going to help to build up the proprioception if it is engaged. For pain reduction, we all know we can start with the pendulum exercises, pendulum clockwise, counterclockwise, back and forth. These are all good exercises to alleviate some of the pain. For scapular stability, you can try in different position, like standing, inclined position, and more weight bearing position, quadruped position. So these are all good for the scapular stability. These are very basic exercise we gave to any kind of shoulder patient. There's another exercise called tabletop arm slide. So at the beginning, when patient have massive tear, they cannot lift their arm up. using elastic kind of banded position using the band. So initially I started with the tabletop slide. So this is easy for the patient to perform. So let me show you the video how to perform. আমি especially shoulder rotator cuff tendinitis থাকলে আমি কিছু So you can see how I'm doing. I'm speaking in our language in Bangla, but I'll discuss in English. Okay, so you should go behind back. Patient can do sitting, or they can do standing on the using the kitchen cabinet. So when they're doing, they should not slouch. They should bend from the hip or bending forward bending, but not slouching. So that's the most important. They can make a small V. Like if you use elastic band, you can use a loop bands, or you can tie elastic band and then make a small V. Back should be straight, should not slouch. That could be easy for the patient before you start any kind of elevation. The next slide, wall slide with resistance band. When you see that tabletop slide is easy and patient can elevate and not too much, it's not painful, then we can do wall slide with resistance band. Let me show you the video how to perform. Let me show you this one. So again, the same way, you're going to use this loop band. So one leg forward, one leg back, and then you can slide your arm up on wall. So here, when you put one leg forward, one leg back, actually you're engaging your posterior sling, and you are working on your scapular muscle, engaging your sling, serratus anterior, and you're doing your elevation. So this is a very good exercise if patient can tolerate without pain, and that can help patient's arm elevation pain-free. And when it's this easy, the progression would be stepping up with the arm elevation. So usually I tell the patient to do 10 times on the right foot forward, then 10 times with left foot forward. So you're engaging both side of the slings. Then I'll show you how to do on the step up and arm elevation, but patient should have a good balance. If you find the patient is really elderly, they might not be appropriate for this exercise. So here I also engage my gluteal muscle and posterior sling. You can do 10 times with right foot and then 10 times on the left side. So these are few kind of idea how we should be working on this kind of patient. We can start with isometrics, external rotation, internal rotation, flexion. We can continue this way. We can do some rowing exercise, low row, mid row. These are good exercise for the scapular stability. And according to Jeremy Lewis, he mentioned about the shoulder symptoms modification. If patient have difficulty lifting their arm, lots of shrugging, then we can do a few other modification like alteration of the thoracic kyphosis, maybe good posture, scapular positioning techniques. We can support the scapula with our hand when the patient is lifting their arm up, or humeral head. You can see here how we can reposition the humeral head. If it is translated superiorly or anteriorly, you can use some kind of belt and pull backwards, and that might help repositioning the humeral head. So these different ways we can modify patient symptoms and perform the pain-free movement. There are other consideration. Taping might be helpful if patient have really kind of rounded shoulders. This taping might be helpful short term. Electroacupuncture, I usually do electroacupuncture. I have been practicing for last 10 years. And I found this really helpful when I combined with my treatment procedure. Though maybe the research doesn't support a lot, or because probably there might not be quality kind of research happen on this area. But I find when I combine electroacupuncture, it works really good. And patient have a lot of difficulty, they can do exercise in the pool. That might be helpful for them. And also I mentioned engaging the kinetic chain could be very helpful. Mirror therapy could be also important because I mentioned this patient, they have kind of sometimes they lose their proprioception. If you give some kind of graded motor imagery techniques like using the mirror, it might also help to gain their range of motion and function. There's an article published. It says spinal manipulation, electric dry needling in patient with subacromial pain syndrome. They find that it helps. It says that it can result in a greater reduction in pain, disability, and medication intake than non-thrust manipulation, soft tissue mobilization, exercise, and interferential current. So they did some kind of compares with other modalities, and they find when they do manipulation and also electric dry needling on electroacupuncture, it works better than other treatment options. Usually I target two different muscle, like two different nerves when I do acupuncture. One is suprascapular nerve and axillary nerve. The suprascapular nerve supplies your supraspinous tendon and infraspinal muscle and supra, and axillary nerve supplies your deltoid and your teres minor. So when I modulate these two nerves, it can affect these muscles. So if somebody have inhibited muscle due to the pain or atrophy, disuse, if you modulate these two nerves, your muscle can function better. So and the patient can perform their exercise better. So when I do acupuncture or electroacupuncture, I target these two nerves, suprascapular and axillary nerve. And the nerve points are, I target, this is your suprascapular nerves. It goes this way. This is the axillary nerve. It branches this way. So usually I target this point, this rectangular point, and another needles here and one needles here. And I put needles here, the suprascapular nerves kind of more kind of easily accessible. And another needle in this area. So in this way, I can target suprascapular nerve and your axillary nerve. And I find it works really good. Okay, so I'm almost done. So mirror therapy is also important because it says, it can, if you move your unaffected arm extremity, that help, like because when you have kind of for a long time you have this massive tear pain, it can inhibit your cortical area of the brain. So when you do a mirror therapy, it helps to gain your range of motion and patient get more confident to move. So it says mirror therapy view reflected movement of the unaffected extremity that activate your premotor and primary motor cortex. So how to do that? I'm going to show you a short video, then I'm almost done. So I took this video from the Physio network. They have a very good article on this topic. So here you can see how we can do the mirror therapy for a patient. So patient's right shoulder is involved. So he's lifting his left arm up, I mean the good arm up, but in the mirror, he's seeing that he's lifting his affected side. So that kind of influence your brain. So this way, usually we do the mirror therapy, and then there are a few steps what you should be doing. But since this lecture doesn't actually, we don't have much time to cover that area. But mirror therapy can be an option for patients who have a lot of pain, cannot lift their arm up. Okay, case study. There's a one patient I am seeing right now. Just let me quickly go through this MRI report, so I'll not take much time. So this patient had massive tear, and you can see the tear size is 5.7 centimeter. 5.7 centimeter in AP dimension, and medial to lateral it is 5.6 centimeters. So I mentioned before that if the tear is more than 5 centimeters, this is a massive tear. So for him, there are severe, let's see, massive tear of supra and infra. There's two tendons are involved. They have massive tear of these two tendons. They have a fiber retraction. As I mentioned, the fiber retraction at the level of the bony glenoid. So that means the retraction is really bad and it retracted towards the glenoid, the level of glenoid. So tendon teres minor is intact. So that's a good thing that they have a teres minor is intact. Patient have, it says the subscapular is suspected that they have a partial tear. So basically his supra and infra has massive tear at more than 5 centimeter and more than 5 centimeter. Patient have fiber retraction up to the glenoid and partial tear in subscapularis. So what do you think? The patient should go for surgery or not? Patient, he's a mechanics. He has to do a lot of kind of heavy activities, that needs heavy lifting, pushing, pulling. So for this patient, surgeon gave him a choice that he should go for surgery. But patient declined. He said, no, I don't want surgery because I'm not going to go back to my work. So in that case, probably surgery is not an option, but I told him that it might get worse eventually. If you see patient's range of motion here, so that he's a very strong person, so his range is quite good and he's almost pain-free. Though his MRI report shows more than two tendons are involved, massive tear, tendon retraction up to the glenoid level, but his range is good. He's almost pain-free. So he decided not to go for surgery. Okay, Marcel, can you lift your arm up forward? That's good. It's almost, I think, 160, 70 degree. Now you can bring it down. Let's see sideways.
Like this?
Abduction. Yep. And how is your pain level?
Yeah, I can feel it,
Can you go any further?
That's probably about it.
Okay. So you can bring it down. Let's see hand behind back.
That's it.
Okay. Yes, so I can see it's very much limited. Okay, thank you very much. You can see the range is not that bad. So for this patient, I treated like elevation with weight, tabletop slide with the band. He has intact teres minor. So we did some external rotation with the light weight, like 5 pound weight, wall push-up, wall slide. That is my initial treatment. Then when patient gets better, then I added this wall slide, banded wall slide. Going up, yep. The rowing exercise. I did some isometrics, internal, external rotator. This is kind of walk out sideways. He's not actually moving his arm, just some tension and then walk out sideways so that you'll get some isometric contraction, but I don't want to do any excessive rotation. So he's doing both ways, internal rotation, internal rotator, external rotator. And I did acupuncture for him. I targeted those suprascapular nerve and axillary nerve. So I think that's all. Sorry if I actually took some extra time. So I am done, Dr. Singh. Sorry for that long lecture. I think you are muted, I think.
Yeah. I think this was a very, very detailed lecture, Dr. Hassan. A lot of cool information. Wow, this was
Thank you
a
very
lot
much.
of information. More than I even thought. I mean, that was a lot of information, I mean, for this lecture. I mean, there are so many things you can use and apply this in the patient practice. I mean, for your patients. I mean, this was like very clinical, very application based, very decision making based. This was one of the probably one of the best lectures we've taught in the last few months. Yeah. Great job,
Thank
Dr. Hassan. I think people enjoyed it. You can just look at the chat box. I don't have to validate anything.
Thank you so much.
Yeah. So guys, as you guys know, we are planning to teach in Delhi and Bombay in April. And what we do is we usually run like a 10% discount after we do these lectures. I mean, if you sign up, I think within an hour, you get that discount. And yeah, if you have any questions, feel free to reach out to Dr. Dhrumi, or you can share the message on WhatsApp group. If you have more questions regarding this lecture, feel free to share on the chat box. This will be shared on YouTube so that you guys can relook at it. This was a lot of good information. Very, very good information. I mean, because all of us see this diagnosis in the clinic. So yeah, attempt the quiz following this lecture if you want a certificate. I think Dr. Hassan prepared 10 questions for you to test on so that you guys can see how much you learned from this. Dr. Hassan, I think you're muted. Any final words of wisdom? I think this was a very, very informative lecture. I think the videos you added were amazing. I mean, they were, I think, very detailed, very informative. I mean, this was a really, really good information, very informative lecture. For a
Actually, when I
diagnosis, all of us study in PT school, but I think you brought like new evidence and new perspective for this diagnosis. So very, very nice.
Thank you very much. Actually, when I was preparing for this lecture, I learned a lot, but we usually don't dive that kind of deep, because when you give a presentation, you should read all the research, papers and everything, and many things are very new to me.
Yeah, I think I like the electro acupuncture because we don't do electro acupuncture in the US. We do like dry needling with electrical stimulation, which is similar, but not exactly same. Probably the practice standards are a little different. And I
I find it
mean,
really helpful. Like when I do it, at least if the patient get 10-15% better, why not? Like patient have a lot
yeah,
of
yeah.
pain, they can't even do anything. If you can modulate the nerve and reactivate the muscle, so why not?
Yeah. I kind of agree with you on that. I mean, we always talk about doing manipulations to create like a neuromodulatory effect. But I mean, I think Dr. Hassan was targeting the nerve, which was a kind of interesting thought process. I think it makes sense though. Guys, do you have any questions? Do follow us on Instagram, Facebook, YouTube. And I think we share a lot of information there. All the previous lectures, free lectures are on YouTube, so you guys can go back and relook at them. And I mean, I think we do this so that you guys can learn. I mean, because there is a definite gap between what you guys have been exposed to and what information is coming out. I think if you look at the research, I mean, I think the amount of research I see is ridiculous. Sometimes it's hard for me to even keep track of everything. But I mean, I think we try our best to actually make sure that you're practicing as per APTA guidelines, practicing as per AON guidelines. Dr. Steve is here. Welcome, Dr. Steve.
That is cheap.
Can you guys unmute Dr. Steve? Role of mechanical dysfunction in rotator cuff tear, absolutely. I think we talk about anterior glide medial rotation being one of the factors if you have attended our shoulder module. So I think Dr. Dhrumi will unmute Dr. Steve. Give me 1 second, I'll message her.
There we go. Fantastic. Yeah, I've been listening in the whole time. Really great lecture. Thank you, Dr. Hasan, for all your preparation and work.
Thank you, Dr.
Yeah,
Ford.
I'm also here just to make myself available to the guys that tuned in today that are listening. Obviously, we bring a lot of great information. Our masterclass does, Dr. Singh and I do as well. For the practical side of things, you know, we've got our hands-on courses, and you guys feel free to join us for those. Like TJ said at the beginning, we'll be in New Delhi and Mumbai for about 6 days each. We'd love to see you guys there. And yeah, looking forward to more to come. We hope that our gym master class will be able to start teaching in India and perhaps in Canada as well, various parts of the world. So
Thank you, Dr. Ford.
yeah,
Hopefully in future in Bangladesh too.
yeah, oh yeah, definitely. We have plans.
Yeah, plans, yeah, for sure.
Bangladesh would not be difficult. I think we're also looking for maybe somewhere in the UAE. I don't know. We'll see.
Guys, do you have any more questions? I think you should definitely attend our shoulder module. I think we do talk about anterior glide medial rotation as one of the movement dysfunctions that can cause rotator cuff tear. We do also talk about certain cervicothoracic issues, rib cage issues. And that's why the program is 1 year, because so that you understand things comprehensively. And just treating simplistically or treating like treating just one segment. Is it a movement impairment syndrome? Yes, it's a movement impairment syndrome. We do talk about it in like greater detail in the shoulder module. Yeah. Any more questions, guys? Thank you, Dr. Hasan, for your time. I think this was an amazing lecture. I think I'm going to probably go back and look at it on YouTube when it's uploaded.
Actually,
I learned some cool ideas. I mean, you can always learn something. I mean, after you look at stuff. I mean, this was, I think, you gave us some great ideas to actually look at. So thank you so much, Dr. Hasan. Very, very informative.
Again, I'm very glad to part of the gym, the master class. Thank you so much for the mentorship, you and for Dr. Ford both.
Can scapular mechanics also create? Absolutely. I mean, we talk about that. I mean, all the time. I mean, Kibler, I think, has published a lot of stuff on it. And that's why, I mean, yes, we do 1 hour lectures, but I mean, I think sometimes it's not enough time to actually go through differential diagnosis. And that's why we try to pick one topic and spend more time on it. And I think we'll continue to do so. We're going to probably talk about scapular mechanics. I think Dr. Amit Banwal has done a lecture on scapular mechanics. It's on YouTube, and you can go back and relook at it. I think he's spoken about altered scapular mechanics affecting various parts of the shoulder and affecting like rotator cuff. Yeah, so you can go back and relook at it. I think, and that's why we do this, because we can talk about one diagnosis in greater detail and then continue to do so, because I mean, more and more research is coming out, and these are common diagnoses. These are not very uncommon things. I mean, we see them all the time, right? Yeah. Okay. Thank you guys. Thank you guys for your time. I think please take the quiz. And then if you have any questions, do reach out to Dr. Dhrumi. Thank you guys.